Balls of fire. Has it been a week already? My, how time flies. Welcome back to your education on all things pertaining to your gynecologic life. I'm Menopause Taylor, a gynecologist who is determined to empower you with an understanding of everything you deserve to know. Currently, we're working our way through a unit on your 3 reproductive hormone phases: pre-menopause, perimenopause, and post-menopause. And right now, we're still addressing the pre-menopausal time in your life. And I'm educating on all the pre-menopausal things that can be problematic or perplexing. So this is video number 470, and it's all about pre-menopausal uterine fibroids, fibroids of the uterus. Now, most women have heard of fibroids of the uterus, but they typically don't know much about them. Some women even have the name misconstrued. Years ago, I had a patient call them fireballs of the Eucharist. She'd heard of them, but had not heard of them correctly. So be sure to note that we're addressing fibroids, not fireballs, and they're in the uterus, not the Eucharist. Goodness gracious, great balls of fibroids. But even women who do know the correct name typically know very little about them. So I'm going to ensure that you know everything you need to know in order to understand and manage your premenopausal uterine fibroids. Now, you will not find a stand-alone chapter on uterine fibroids in my book, Pre-Menopausal or otherwise. But you'll get everything you need here in this video. So stay here and watch it. I've given you 3 videos on uterine fibroids in the past. They were videos number 135, 136, and 137. But in those videos, I focused mostly on post-menopausal women. Today, I will focus on pre-menopausal women. So let's start with anatomy. Here is a Play-Doh model of your uterus. Notice that it's really kind of boring in its appearance. I mean, there's just not much to it. And your uterus really is like this blob of Play-Doh. It's actually similar in consistency to this Play-Doh too. So your uterus is really just a blob of pink tissue. But the pink color is significant. What other anatomical structures are pink? Your muscles. Well, guess what? Your uterus is nothing but a muscle. And like any other muscle in your body, your uterine muscle can do 3 things. It can relax, it can stretch, and it can contract. Most of the time, your uterine muscle is relaxed. That's when you feel nothing. When you get pregnant, your uterine muscle stretches and stretches and stretches. And when it's time to deliver the baby, your uterine muscle contracts. That's why we call labor pains contractions. But your uterine muscle also contracts to expel the thickened uterine lining from your uterus if you don't get pregnant. And that's what we call menstrual cramps. But the muscles in your body contain another kind of tissue also, in addition to the muscle. They also contain fiber. And the fiber is what attaches your muscles to your bones. Most of the fiber in your muscles consists of thick bands only at the very ends of the muscle. But that is not the case with the fiber of your uterine muscle. When it comes to your uterus, instead of fibrous bands, there are fibrous flakes scattered throughout the entire muscle. And the fibrous flakes are what give your uterus its shape. So here, I have some oatmeal flakes, and I'm going to sprinkle them throughout our pink blob of muscular tissue. The oatmeal flakes represent the fibrous tissue of your uterus. Now notice that the word fibroids sounds like the word fibrous. And that's apropos because fibroids are fibrous. And it is precisely the fibrous tissue that grows to create fibroids in your uterus. So fibroids of the uterus consist of fibrous tumors that grow in the muscle of your uterus. And a fibroid forms when the flakes of fibrous tissue start overgrowing in the muscular tissue. The key distinguishing feature of a uterine fibroid is that it is a solid mass. Not only is it solid, it's also hard and it's heavy. The distinction I'm making here is very important. Why? Because there's another entity called a uterine polyp. And women commonly confuse uterine fibroids with uterine polyps. A uterine polyp is not hard and heavy. Instead, it's soft and light. And I'll be giving you a video on uterine polyps next week. Just know that they are two completely different things. Nobody knows what causes uterine fibroids. All we know is that your uterus creates them. And once they exist, various factors, including your sex hormones, can act on them to make them larger or smaller. So I guess it's kind of like a movie production. There's a creator and there are actors. Your uterus creates the fibroids and your hormones act on the fibroids. Uterine fibroids start out tiny. But over time, they grow. And then they can get larger and larger and larger. And as they grow, they just occupy more and more of your uterus. As you can see, your uterus is not very big in the non-pregnant state. Here is a life-sized model of a female pelvis. This represents a woman in the supine position. She's lying down. Here's her butt. Here's her abdomen. Her head would be over here, and her feet would be over here. Now, I'm going to remove this front part of the model. This model represents the anatomical structures inside her pelvis. And you can see that the uterus is here. It's just below the bladder. And it's actually really pretty similar in size to the bladder. So your non-pregnant uterus is tiny. And uterine fibroids can be, and very commonly are, larger than the uterus itself. And this is true of individual fibroids. A single fibroid can easily be much larger than your entire uterus. Unfortunately, though, uterine fibroids usually develop in crops. You can have a single isolated fibroid, but that's unlikely. It's more likely that you only know about the largest fibroid. And there are usually crops of smaller uterine fibroids that you can't detect because of the largest fibroids. No matter what, fibroids make your uterus larger than it's supposed to be. In the past, I've used avocados as props for the uterus and cervix, and that's because the uterus and cervix are two structures that are attached in a way that is not visibly evident. So instead of seeing a pink prop of the uterus, you've grown used to seeing a green prop of the uterus. So now, I'll switch to the original green uterus prop that I've used in the past, and I'll switch to a green fibroid uterus prop too. So, here is the larger than normal sized uterus without fibroids that I've used in the past. Now, notice the shape of this model. Obviously, it's shaped like an avocado, but it's a perfect prop for depicting the shape of your uterus, other than the fact that it's a lot larger than your non-pregnant uterus, and of course, it's green. But the avocado actually consists of two anatomical structures rather than just one. This narrow portion here at the bottom is your cervix. It is the door to your uterus. And the wide portion up here at the top is your uterus. Together, they constitute one structure for which you cannot tell where one ends and the other begins unless you look at the cells under the microscope. Now, here's a uterus with fibroids. And as you can see in this model of a fibroid uterus, the fibroids can be in various locations. A fibroid can be deep, deep, deep inside the uterus, right next to your inner lining. We call these submucous fibroids. Or a fibroid can be right in the middle of the thick muscular uterine wall. We call these intramural fibroids. Or a fibroid can be near the outside wall of your uterus, far from the inner lining, and we call these subserosal fibroids. Or a fibroid can dangle off the inner or outer surface of your uterus on a stalk, and we call those pedunculated fibroids. They're like mushrooms. The word pedunculated comes from the word pedicle. Now, most women who have uterine fibroids have a variety. They have them in all of these locations. So a typical fibroid uterus really does look like this. Back in the Cancer in General unit, I taught you that all masses are called tumors. Well, that means that fibroids of the uterus are tumors. Fortunately, they are typically benign, but boy, can they be ugly. Fibroids can make a uterus look unrecognizable. Here are a couple of photos of fibroid uteri. These photos of fibroid uteri are not even recognizable as uteri. They are distorted in size, shape, and color. They look monstrous, don't they? Well, how common are uterine fibroids? They are very common. 40% of women have fibroids of the uterus. The uterus creates them. Well, this high incidence tells you that most uterine fibroids are benign. 40% of women bear uterine fibroids that are completely benign. But can they become malignant? Yes, they can. Fortunately, it's rare. The incidence of a malignant uterine fibroid is less than 1 in 1,000. The more common problem is masking of other diseases. I mean, how are you going to know if another disease develops with all these fibroids in the way? Your sex hormones, primarily estrogen, act on them to make them grow. And normally uterine fibroids grow slowly. Pregnancy makes them grow more rapidly. And after pregnancy, they usually shrink a bit. Most women don't even know they have uterine fibroids when the fibroids are really, really small, like these. Most small uterine fibroids cause few or no symptoms at all. But as they start getting larger and larger, they can cause a variety of symptoms, including heavy bleeding, abnormal bleeding, pelvic pain, pelvic pressure. Here's why they cause bleeding. Remember that I told you that your uterus is a muscle? Here's the pink muscle, and here's the same thing in green Play-Doh. Well, the fact that it's a muscle means that it can contract. So anytime there's bleeding, your uterus contracts to squeeze on the blood vessels in order to stop the bleeding. Well, with this big fibroid in the way, the muscle cannot contract. It tries, but the fibroid is in the way, so the uterus just keeps bleeding. That's why women with uterine fibroids may have bleeding in between periods or heavy bleeding during their periods. And all those attempts at contracting to stop the bleeding are painful. Your menstrual cramps were nothing but contractions of your uterine muscle. Were they painful? And labor pains are nothing but contractions of your uterine muscle to expel a baby. Were they painful? Well, this is why women with uterine fibroids can have pelvic pain. And fibroids are hard. They're hard and they're heavy. And the bigger they get, the more they weigh. And all that extra weight sits on all your pelvic structures, pressing down on them. So many women with fibroids have pelvic pressure. Well, what about diagnosis? Diagnosis of uterine fibroids is easy. There are essentially two ways to diagnose uterine fibroids. Your doctor can feel them on pelvic exam, or your radiologist can see them on pelvic ultrasound. Pelvic exam is adequate for diagnosis of large or multiple uterine fibroids. Part of your pelvic exam consists of a bimanual exam. Bimanual means two hands. For a bimanual pelvic exam, your doctor inserts two fingers of one hand into your vagina and places the other hand on top of your abdomen. And then he or she just presses up with the vaginal fingers and presses down with the abdominal hand, and voila, what do you know? In between the two, he or she can feel your uterus to determine its size. Large uterine fibroids will make your uterus feel much larger than expected on bimanual pelvic exam. And if you have multiple uterine fibroids, bimanual exam will reveal an abnormal uterine shape too. So that's how you can diagnose uterine fibroids, by feeling. Alternatively, your doctor can diagnose uterine fibroids by seeing them on a pelvic ultrasound. They show up very clearly on pelvic ultrasound, so a simple pelvic ultrasound can determine whether or not you have fibroids. Not only that, a pelvic ultrasound can usually identify the location and size of your fibroids. So diagnosis is not a problem. Well, what happens to your fibroids as you enter perimenopause and postmenopause? Do they shrink? Do they disappear? No and no. And this is an area of great misconception and mismanagement. Both patients and doctors tend to believe that fibroids shrink or disappear when you become peri or postmenopausal. They don't. If you have premenopausal fibroids, you will still have them when you become peri or postmenopausal. And fibroids can cause problems during peri or postmenopause, even if they never caused any problems during premenopause. So don't fall for magical sounding disappearing acts. Uterine fibroids can definitely interfere with successful HRT for menopause management too. The most common way they interfere is by causing bleeding when you shouldn't bleed. But this is precisely what they do during your premenopause too. Well, what about management options? What can you do about your premenopausal uterine fibroids? Now, this is where you have many options. In fact, you have so many options that it's easy to do the wrong thing for your situation. I will present all the options for management of uterine fibroids, but I'll tell you from the start that all women with uterine fibroids need tailoring of the options to their particular circumstance. It is so common for both patients and doctors to do the wrong thing for a particular situation. So if you have premenopausal uterine fibroids, definitely schedule a consultation with me at menopausetailor.me. I will teach you all your options and present the pros and cons of each. There is nothing that is right for all women. We are not robots. So let's start by addressing why you might want to manage your fibroids. You may have very heavy periods, or you may have painful periods, or perhaps you have pelvic pressure. Well, the very fact that women manage their uterine fibroids for different reasons means that the different management options accomplish different goals. So start by defining your goals. I always say begin with the end in mind. That means think about the big picture. Do not do something that manages your uterine fibroids only temporarily if your goal is to manage them permanently. The options for uterine fibroid management differ greatly in terms of whether they are short-term or long-term solutions to your fibroids. In fact, this is such an important distinction that I think it's best to separate the management options into two categories, short-term and long-term. And you'll see right away that there are a whole lot more short-term management options than there are long-term management options. Here's a whole list of the short-term management options. Do nothing, progestin-only contraception, estrogen plus progestin contraception, antihormonal medications, uterine artery embolization, or UAE, laparoscopic radioablation, and uterine myomectomy. That's quite a long list. And I will tell you what each one can and cannot do in just a bit. But what about the long-term management options? What if you want to get rid of your uterine fibroids forever and ever and never have to deal with them ever again? Well, that's a much shorter list. In fact, it doesn't even qualify as a list. It's only one option. You have to get rid of the organ that created the uterine fibroids in the first place, and that's your uterus. So that means hysterectomy. And any kind of hysterectomy will be a permanent solution for your uterine fibroids. As long as your uterus is gone, the uterine fibroids will be gone. Okay, so let's go through these one by one. And since we'll be comparing what each one can and cannot do, let's make one of my nifty charts as we go along. Here's a skeleton of the chart. Here you see that the first column divides the management options into short-term and long-term. The second column delineates all the different management options. The third column is where we'll insert what's entailed with each option. The fourth column is where we'll designate what each option can do. And the fifth column is where we'll designate what each option cannot do. Okay, so your first option is to do nothing. And this is an option that is very common intentionally or unintentionally. So you can just put up with your fibroids, your heavy bleeding, your painful periods, and your pelvic pressure. It's possible that you'll have none of these symptoms. In that case, you may or may not even know that you have uterine fibroids. Regardless, doing nothing is an option. Of course, it will accomplish nothing too. Either your uterine fibroids will never be a problem for you, or they will eventually become a problem for you by manifesting a symptom or a threat. So doing nothing can't accomplish anything. Let's fill in these cells on our chart. Our second management option for uterine fibroids is any kind of progestin-only contraception. These include all the following: progestin-only birth control pills, also called the mini pill; progestin shots, known as Depo-Provera; progestin implants called Norplant, Nexplanon, or Implanon; and progestin intrauterine devices, or IUDs. The most that any of these can do is make your periods lighter or make your menstrual cramps weaker. They cannot do anything to your actual fibroids. They will not impede creation of new fibroids. They will not slow growth of already existing uterine fibroids. They will not get rid of uterine fibroids. So here it is on our chart. You're probably already groaning with how little these first two options can accomplish. The sad thing is that these first two options are the most common of all. They get you nowhere, and both patients and doctors mistakenly believe that they have some kind of benefit. Well, what about the third option, estrogen plus progestin birth control? Now, this is the first hint of progress, but it's just a hint. Estrogen plus progestin birth control includes birth control pills, birth control patches, and birth control vaginal rings. The difference between progestin-only birth control and estrogen plus progestin birth control is the estrogen. And I've told you that estrogen can make your uterine fibroids grow. So you'd expect estrogen plus progestin birth control to offer fewer uterine fibroid benefits than progestin-only birth control. But oddly, that's not the way it is. Estrogen plus progestin birth control can actually limit the growth of your uterine fibroids. Well, that means it can make your periods lighter or make your menstrual cramps weaker. It's not going to prevent them from developing in the first place, and it's not going to get rid of any uterine fibroids you already have. But this is the first management option that can make any difference whatsoever. So here it is on our chart. The fourth management option for uterine fibroids is an anti-hormonal medication. Anti-hormonal medications are exactly what the name implies. They block your sex hormones. So anti-hormonal medications block your estrogen and progesterone. Essentially, they put you into a state of post-menopause. That will slow or stop your uterine fibroid growth, but it will also stop your periods completely and give you all the symptoms and diseases of post-menopause. They will not get rid of your uterine fibroids completely or permanently. These are not medications that you can take long term. And when you stop the medication, your uterine fibroids will start growing again. Most women claim that anti-hormonal medications are more miserable than the fibroids themselves. So here is our chart again. The fifth management option for uterine fibroids is uterine artery embolization, and the acronym is UAE. UAE is also the acronym for United Arab Emirates, but you already know that the United Arab Emirates cannot manage your uterine fibroids. Uterine artery embolization entails clogging the arterial blood supply to your fibroids while hoping to avoid clogging the blood supply to the rest of your uterus. A uterine artery embolization is something that a radiologist does. First, he or she identifies the blood vessels supplying your uterine fibroids. Then, he or she injects a material into those arteries. And the material consists of particles that expand in the artery to prevent the flow of blood and oxygen to the individual uterine fibroid. It's really the same thing that happens when someone has a heart attack. The tissue beyond the blocked artery dies. Obviously, the radiologist has to block the blood supply to each uterine fibroid individually. This means that uterine artery embolization will only target your largest fibroids. The single fibroid supplied by the blocked artery will stop growing and maybe shrink a bit, but it will not disappear completely. But if you have lots of uterine fibroids, like most women, uterine artery embolization will leave most of them unaddressed. So this is a procedure that is reasonable if you have only one big uterine fibroid. It makes no sense whatsoever if you have multiple uterine fibroids or if your fibroids are small. Unfortunately, many women undergo uterine artery embolization even though they are very poor candidates for the procedure. So rarely does uterine artery embolization get rid of your fibroids permanently. And it does not prevent new fibroids or growth of non-embolized fibroids. So let's add this to our chart. The sixth management option for uterine fibroids is laparoscopic radioablation. Now I know that that's a mouthful, but I'll break it down for you. Laparoscopic radioablation is an outpatient surgical procedure. A laparoscope is a surgical telescope. Your doctor inserts it into your belly button, and then through it, he or she can look into your pelvis and see your fibroid uterus. Then, while looking through the laparoscope at your fibroid uterus, he or she inserts a needle carrying radio frequency into each fibroid individually to destroy or shrink each individual fibroid. The goal is to shrink the fibroids while avoiding damage to any surrounding normal uterine tissue. But how well your surgeon can target each individual uterine fibroid depends on a lot of things that nobody can predict beforehand. The size and location of the fibroids can limit access. So unless you have just one big, easily accessible fibroid, the success of this procedure varies greatly. It does nothing to prevent development of new fibroids. And any uterine fibroid that it does not destroy completely can certainly grow after the procedure. So laparoscopic radioablation is only about as good as uterine artery embolization. Neither one prevents new fibroids or prevents growth of other fibroids or gets rid of the fibroids completely. So let's put it on our chart. The seventh management option for uterine fibroids is uterine myomectomy. A uterine myomectomy is also a surgical procedure, and it's possible to accomplish it in a number of different ways. We call the different ways of going about it approaches. So there are several approaches for uterine myomectomy. Your doctor can do it via a laparoscope, a surgical robot, or through a small skin incision. There's no better or worse way. It just depends on your fibroids, your goals, and your surgeon's skills. A uterine myomectomy entails literally digging each individual fibroid out of your uterus and then sewing up the hole where the fibroid existed. Now, you have to realize that your uterus bleeds profusely when you dig a fibroid out of it. So each hole created by removal of a fibroid will result in blood loss. And depending on the size of each fibroid, the number of fibroids, and the ease of removing each fibroid, it can add up to a whole lot of blood loss. Of course, there's no guarantee that your surgeon can even get to all the fibroids. And there's no way to dig out the smallest fibroids. So this is a big surgery without the guarantee of long-term results. Uterine myomectomy does not prevent development of new uterine fibroids. It does not prevent growth of remaining uterine fibroids. And it usually does not get rid of your uterine fibroids once and for all. So here's our chart again. Notice that thus far we have 7 management options for uterine fibroids, but not a single one of them gets rid of all your fibroids once and for all. All 7 of the management options we've discussed thus far will likely put you in a situation of having to deal with your uterine fibroids again later. All of them have managed your fibroids in the short term only. And that brings us to the 8th management option for uterine fibroids, hysterectomy. I've taught you about hysterectomy in the past, and you've learned that there are many different kinds of hysterectomy. There's a partial hysterectomy, which is removal of your uterus only. There's total hysterectomy, which is removal of the uterus and the cervix. And there's total hysterectomy, which is removal of the uterus and cervix, and bilateral salpingo, both sides of the tubes, oophorectomy. So, you have to understand there's different options to take care of this. Well, typically, uterine fibroids exist only in your uterus. So the key to permanent long-term management of uterine fibroids is to remove the organ that creates the fibroids in the first place. That's your uterus. So, what you choose to do with all these other organs is entirely up to you. What matters is that you get rid of this. What you choose to do about all these depends on your particular situation. But the only way to get rid of your uterine fibroids once and for all, forever and ever, is to have a hysterectomy. So let's add that to our chart. So there you have it. A very common pre-menopausal problem with 8 different management options, only one of which actually gets rid of the problem once and for all. Now notice what's not on the list of management options for uterine fibroids. Endometrial uterine ablation. Over and over again, I encounter women who had an endometrial uterine ablation to supposedly manage their fibroids. Well, they've all been scammed. Endometrial uterine ablation does nothing for uterine fibroids. All it does is destroy the inner lining of your uterus so that it cannot bleed. But uterine fibroids don't exist in just the inner lining of your uterus. They exist in all these layers of your uterus. And bleeding is only one of many symptoms they cause. So do not fall prey to anyone who tells you that endometrial uterine ablation will manage or treat your uterine fibroids in any way. It won't. So here's your summary. Uterine fibroids are benign fibrous tumors in the uterine muscle. They cause heavy bleeding, pelvic pain and strong menstrual cramps, pelvic pressure. Diagnosis is via feeling the fibroids on pelvic exam or seeing the fibroids on pelvic ultrasound. And of the 8 possible management options, only hysterectomy constitutes long-term, permanent eradication of the uterine fibroids. The chart is also your summary, and you'll find it via the link in the description box just below the screen, and you'll also find it at menopausetailor.me. If you have uterine fibroids, you should already be at menopausetailor.me scheduling a consultation with me. Because if you have uterine fibroids, you definitely need a consultation with me. I cannot tell you how many women have something done for management of their uterine fibroids only to find out afterward that what they did failed to meet their management goals. They don't discover the subterfuge until they have a consultation with me. So save yourself a bunch of mistakes. Have a consultation with me before seeing your doctor about your uterine fibroid management. I will ensure that you have the whole story and the whole truth. After you schedule your consultation with me, subscribe to my channel and my newsletter. And after that, follow me on social media. And I will see you in a week, my dears. Bye-bye.